If you have not received the handout, evaluation form instructions, and sign-in sheet for today's webinar, you can print them from Trinity Health's website at the link that is in that. The webinar has been approved for 2 Category 1 CME. To qualify for these credits, you must attend the entire session and follow the instructions for the CME online evaluation form to complete evaluation and receive your certificate. Representative Nancy O'Brien-Abel has nothing to disclose, nor any other of the planning members. Please your phones by pressing *6. If you have questions throughout the presentation, you should send them via the Q&A screen to the right of your screen in the chat. Nancy will respond to the questions at the end of her presentation. Please your questions to those that relate to today's content only. And it's my pleasure to introduce you to our speaker, Nancy O'Brien-Abel. She is a perinatal clinical nurse specialist with over 30 years experience in caring for women with normal and complicated pregnancies. Clinical instructor in the University of Washington School of Nursing and teaching associate in the Department of Obstetrics and Gynecology at the UW Medical School for 20 years. She is actively focused on multidisciplinary education and collaboration. She is a nationally recognized speaker and author on fetal monitoring and the care of women in labor and birth. She is an active member in the Association of Women's Health, Obstetric, and Neonatal Nurses, contributing to various position statements, evidence-based clinical practice guidelines, and A1's Fetal Heart Monitoring Principles and Practice books in both 2009 and 2014. Well, as co-authoring chapters on fetal assessment and labor and birth in A1's 2013 edition of Perinatal Nursing. Nancy received her Master of Nursing from the Perinatal CNS program, University of Washington, is NCC certified and an instructor for A1's Fetal Heart Monitoring program. She's passionate about improving the quality of perinatal care for mothers and neonates, and I believe you'll see that as you listen to her presentation today. Please join me in welcoming Nancy. I'm going to pass the ball to you now.
Right, let me see if I can get, it's on desktop. Oh, here it goes. Monitor 1. Everybody, we're just having a little technical gets here. Can you tell me before we start which screen you see? Do you see one with the slide on it or one with a single slide? On.
Here, I was muted.
Can you tell me right now?
Slide.
Only on it, correct?
Yes.
So then under 1.
Actually, I can see I need to put the full slide up because I can also see your
Yes.
script.
Okay, then hit escape. I'm going to get back to sharing.
Here.
Share.
Sure.
Like that. Share my desktop.
Monitor 2. And what?
Now launch your presentation again. Launch your presentation again.
No slide, an individual slide. Are you seeing? Lydia? Lydia? Can you one slide now? It's only one slide. Oh, perfect.
Yep.
One slide. That's all everybody's seeing. Okay, the way this is working, I cannot see any of the questions there's something funny going on here. So all I can see are my slides. I have two monitors, everybody, but I no longer see the messages you type. So we'll just have to, if you have questions, like Lydia said, hold them till the end, and then I will address your questions verbally. We'll unmute, and I can answer questions at that time. I apologize for that. I don't know what is happening here. So again, to begin, thank you, Lydia and Trinity, for inviting me. I'd like to thank the nurses and midwives and physicians that are participating today, and those of you who are individually listening to this at a later date. I'll come to these webinars with a wealth of everyday clinical experience, and my effort in developing these 3 webinars is to help focus your knowledge and skill so that you'll be successful in passing the NCC EFM subspecialty certification examination. Thank you, Lydia, for the welcome. And I also, again, am repeating that I do not have anything to disclose. I'm a rather boring person on that front. This slide actually illustrates an overview of the 3 webinars that are available via Trinity. The first webinar is the one that we're doing today, which is the physiologic basis for fetal monitoring. There are some recording issues on sound in the 2013 version. However, webinar 2 and 3 are still the 2013 versions, and they're still available. In webinar number 1, that our focus will be on fetal oxygenation and heart rate regulation. Also review umbilical arterial cord gases. This is the most difficult information for most folks on the NCC certification exam. And at the end of the course, I will recommend some reading materials. In fact, Lydia has a 1-page document that's available to anyone, which goes over briefly, very briefly, what a breakdown of categories on the NCC exam, and then my recommended readings that are pretty specific to the content on the examination. And so all of you are welcome to that 1-page review for each. It includes all webinars content. Webinar 2, if you decide to listen to Webinar 2, focuses on fetal heart rate patterns, interpretation, and management. And then Webinar 3 has additional considerations in fetal monitoring, a lot of different maternal complications, for example, uterine rupture and abruptions and ruptured vasa previa, those types of things, in case study format, looking at the heart rate tracings. And a little brief, a few minutes on instrumentation because folks miss those questions, fetal heart rate arrhythmias, and then a brief 15 minutes or so on fetal surveillance methods. Throughout these webinars, I've embedded practice questions to get a feel for the exam. And again, I do not see the exams. I have no idea what the kind of the version of exam you will have. However, I'm pretty close in some of the content ideas, and I can write questions. I had done some work for NC many years ago, so I have a good feel of the type of content that they do put onto the exams. And finally, my handout that you have is really a subset of today's PowerPoint. Otherwise, it would go on and on forever. And lastly, like Lydia said, we'll hold questions till the very end, and we have to today because actually I can't see any of the typed questions, so that's really not that effective for me as we continue on today. So let's go ahead and begin. As you all know, in a very simplistic way of thinking, fetal heart rate or the fetal heart rate patterns that we see on the electronic fetal monitor reflect fetal oxygenation. The fetal heart rate patterns help us differentiate the fetus who is well oxygenated and not anemic, does not have metabolic acidemia, from fetus who may be experiencing metabolic acidemia. And that's the real beauty of this tool. Fetal oxygenation is dependent on a number of factors that are both extrinsic and intrinsic to the fetus. So in the next few slides, I'm going to speak briefly about each of these factors. We'll talk about maternal oxygenation, and blood flow, which is imperative for placental exchange at the intervillous space level. And we'll talk about umbilical blood flow, delivering this oxygenated blood to the fetus. And we know that oxygen can be disrupted at any point along this pathway, resulting in changes in the fetal heart rate. Of course, there's changes related to uterine blood flow and placental exchange. We may see late decelerations because those are based on decreased uterine placental perfusion. Or if you see variable decelerations, it can be reflected to umbilical cord compression or occlusion. Also, we'll talk about intrinsic factors. Those are within the fetus. And the main three areas I want to cover in this webinar are looking at fetal circulation, which is different than yours and mine, and look at the shunts that help oxygen be delivered to the fetal brain and the heart and the most vital organs. Also talk about oxygenation of tissue and the unique characteristics that the fetus has that are very different than yours and I, and lets the fetus survive on a PO2 equal to your and my venous blood. And we'll spend a bit of time talking about fetal heart rate regulation. And it's a very complex subject, but we will pull out about 6 key concepts that tend to be more focused on the exam, looking at the branches of the autonomic nervous system, the sympathetic and parasympathetic branches, receptors, chemoreceptors, the importance of cardiac output, and then lastly, a brief conversation about fetal state. Right, so, next slide. All right, so we know that the first intrinsic factor that I listed was maternal oxygenation. And we know that the fetal oxygenation depends on well-oxygenated maternal blood. Maternal hemoglobin levels or concentration, the adequate oxygen saturation, and adequate arterial oxygen tension, which drives the oxygen saturation on the hemoglobin, are needed for fetal oxygenation. Now, good news, which makes this easier for all of us, that we don't really have to focus on this too much, is that for the most part, our women that we care for, our pregnant women, are healthy and well oxygenated. Now, there are exceptional cases that aren't, and my background is critical care OB, so I certainly understand that. But for the most part, in our discussion here, our women are healthy and well oxygenated. A mom, the healthy lungs and heart and vasculature is able to extract oxygen from her environment, deliver the oxygen to the placenta for exchange to her fetus. Conditions that may impair oxygen delivery to the fetus would include things like severe anemia, asthma, heart failure, heart defect, or even maternal seizures. Second factor, and this one is probably more important and what we like to focus on because we can impact this during labor and birth, we're looking at adequate uterine blood flow. Now, adequate uterine blood flow is critical for the passage of respiratory gases and substances across the placenta membrane. Uterine blood flow increases progressively throughout the duration of pregnancy. And when we think about numbers, some people like to know these numbers, is that from about 50 ml per minute blood flow in a non-pregnant uterus to approximately 700 ml per minute in a term pregnancy. And certainly if you're caring for women who have multiples, it may even be higher than that. About 10 to 15% of the maternal cardiac output is uterine blood flow, and 60 to 90% of uterine blood flow passes through the intervillous space within the placenta. So a real take-home here, and that's so important, is the understanding that intervillous space perfusion is dependent upon adequate uterine blood flow. Now, when we look at uterine blood flow and intervillous space perfusion, this is a simplistic drawing from Moore in 2003. I like this drawing because it's simple and yet it gets to the point. I don't know if you can see my pointer on your screen or not, but when we look down at the bottom, I hope you can see my arrow. When we talk about intervillous space perfusion, We love talking about maternal oxygenated blood into the placenta down here at the bottom via the endometrial arteries. And then if you look at the color fountain-like appearance of blood squirting towards the chorionic plate of the placenta, we can think about how maternal blood is propelled by arterial blood pressure, and it spurts fountain-like, if you will, towards the chorionic or roof of the placenta. And pressure dissipates this maternal blood, bathes these protrusions of fetal tissue within the intervillous space, and you can see here this drain has 1, 2, 3 of these type protrusions. Obviously, there's many more in real life, but these are protrusions of fetal tissue and the little chorionic filmy villi at the tips of it. At the tips of those villi, where the exchange of oxygen and nutrients take place, and the removal of waste products, which we'll talk about in a moment. And this oxygenated blood is picked up by the fetal red blood cells here with the intervillous, within the tips of the villi, and is carried to the fetus via the umbilical. And I know you're thinking vein, and that's absolutely correct. Umbilical vein to the fetus. And deoxygenated blood returns via the 2 umbilical arteries back down, successively dividing into smaller and smaller vessels, and eventually into creating an arteriovenous system within each chorionic villus. So the exchange here and removal of CO2 and waste runs into the endometrial veins and then back to the maternal circulation. The exchange mechanisms that take place at the placental membrane, the exchange that happens is quite remarkable. There are a number of different factors that I've listed out on this slide. The first and foremost one, the one I would like you to focus on primarily, is the concept of diffusion. Some people, depends on what part of the country you're in, may call it simple diffusion. Some like to say passive diffusion or just plain diffusion. And this one is important because labor and birth, we always talk about oxygen transference like we're doing today, or removal of CO2. These take place by diffusion. When we give mom a narcotic, it transfers across the membrane via diffusion and impacts the fetus and the fetal heart rate. There's a number of other examples I'll get to in a moment specific to diffusion. We also have facilitated diffusion and active transport, pinotosis, bulk flow, breaks or leaks that can happen in the vessel, which are not desirable, and then independent movement and infection, which also can pass some undesirable infections, etc., across the membrane to the fetus. So since many of you are visual learners, I'm going to go through each of these and just give you a visual of what they are. It might stick a little bit in your memory. So here's diffusion again from high to low concentration across the membrane. So as I mentioned, oxygen is a great example, moving from high concentration in mother across the membrane to the fetal compartment. And likewise, when we talk about CO2, it's much, much, much higher in the fetus. And we'll talk about this when we look into cord gases a little bit later in the hour. Moving from CO2 from the higher concentration in the fetus across the membrane to the maternal compartment, to narcotics and barbiturates, antibiotics. Another one to think about here, a great example would be if you call down to the operating room if you're one of the nurses or resident and asked to monitor the fetal heart rate on a mom and post appendectomy, perhaps at 28 weeks gestation, and you put the monitor on and the heart rate's appropriate for gestational age prior to the surgery, and then post-op, immediately in recovery, you check the heart rate and you put a monitor and you have a heart rate tracing that is almost variability, really minimal variability is all that you see, and it doesn't look like the tracing prior to surgery. And that's because if she had, of course, a general anesthetic, general anesthesia also diffuses readily across the membrane. These are just great examples to think about with the concept of diffusion and why they like to ask questions on this test about diffusion. Water, some electrolytes, urea, uric acid, they all can pass small amounts, again, via diffusion. facilitated diffusion is how we get glucose across the membrane. And here again we have the concept of diffusion, but also a carrier molecule involved, active transport, amino acids, water, soluble vitamins, calcium, iron, phosphates, iodine, potassium, a number of substances. This is against the concentration gradient, so energy and a carrier molecule are usually involved. We have blood flow, which involves hydrostatic pressure with water and electrolytes. Pigmentosis, of course, my favorite, just because it reminds me of the old game of Pac-Man, where a substance is engulfed within the membrane and then transferred through the membrane and then released on the other side. And the best example here would be IgG. As I mentioned, there are some mechanisms that allow transport of substances that are not desired. For example, intact red blood cells. And of course, this is an issue. The best example to think about quickly would be Rh negative mother and an Rh positive baby, or we think about fetal maternal hemorrhage, also, which we'll talk about in the third webinar. The last two to think about, and I've combined them here, would be the transfer of cells under their own power, for example, maternal leukocytes and microorganisms such as those of syphilis in this example, and transfer by creating lesions with infection, where lesions are created and then the infection crosses through these defects in the placental membrane, and some bacteria and protozoa such as toxoplasmosis can get across. Now, there are other substances that are non-transferable that cannot get through the placental membrane, and we think of things like heparin or IgS or IgM, but there are substances that likewise cannot get through the membrane. For the most part, we're talking about those that can readily cross. The next concept, still talking here about uterine blood flow and this interval of space, is to think about this concept about the arteries and ability to autoregulate. So because the maternal spiral arteries carrying this oxygenated blood to the intervillous space are maximally dilated, and lost some of their ability to autoregulate or constrict, uterine blood flow can adversely affect the fetus. And in clinical practice, we have very few ways to increase uterine blood flow. However, what's more important is for us as clinicians to be acutely aware and to be able to manage clinical situations that have the potential to decrease uterine blood flow and placental perfusion. And that's why we're so careful about many of these factors here on this next slide, because all of them have the potential to decrease uteroplacental perfusion. We see more commonly than others, but certainly any of these can happen as on our watch in labor and birth. I put excessive uterine activity at the top of the list, and you can see in RNs tachycystole and hypertonus and abruptio placenta as examples. I purposely did not write just tachycystole. A rationale for that is thinking about a patient actually that I took care of just, a month ago, who had severe hypertension and preeclampsia and was induced at about 30 weeks gestation due to her mom's disease. And for that particular mother-baby dyad, excessive uterine activity was about 2 to 3 contractions in 10 minutes, 2 to 3 contractions in 10 minutes. With 2, we get up to 3 contractions, and we'd have recurrent late decelerations due to the extreme illness mom-baby, the milieu with their dyad. So it's important to think about the mom-baby dyad that you're taking care of, but certainly we will talk more about tachycystole, and we certainly talk about abruption in second and third webinars. Maternal hypotension, obviously there's supine positioning and analgesia or anesthesia. Maternal hypertension, a number of placental changes, which will I'll show you some images of those as well in a moment, and then vasoconstriction. So we are with excessive uterine contractions. Here's clearly tachysystole, where we have more than 5 contractions in 10 minutes. By definition, it's averaged over 30 minutes, but we would all agree that this is a situation here of tachysystole, and it needs to be managed. Our concern about uterine tachysystole, as we all know, is that it decreases uteral placental perfusion and then fetal oxygenation. And I think it's exciting, a lot of the newer literature that's coming out looking at really it may not be the frequency of contractions so much when we look at oxygenation of the fetus, but looking at that whole concept now that's been talked about. Backer was the first paper that looked at this, but looking at less than a minute between contractions, that we need, it increases the risk of a fetal acidemia, and that we need at least a minute between contractions to have the exchange of oxygen and nutrients and removal of CO2 and waste products. And when it's less than a minute, significantly increases the risk of fetal acidemia. That's important because if we have 5 contractions in 10 minutes and each one lasts a minute, and a minute off and a minute on and a minute off, that can work for many babies. However, not to say that we always run the pit up to having 5 contractions in 10 minutes. I mean, that's the max. But if the contractions are lasting longer than 60 seconds, for example, 90 seconds, then that's only 30 seconds between contractions, and that's just really not enough. And if that's a scenario where you have 90-second lasting contractions, they can't have 5 in 10 minutes. It's just frequent for that fetus and will increase our risk of acidemia. We'll talk about this concept in the second webinar. Third to look at would be, of course, hypotension, and we think about it not only in the supine position, illustrated here with mom on her back with compression of the carotid uterus, compressing the aorta and vena cava over the vertebral column, where, again, we know that lateral positioning is more important. We don't want women in the supine position, and that's an important concept. We are having more and more problems with this. I think nurses are, in the sense that a lot of our women are larger. BMIs are increasing, as we all know, and some of the women, I'm not so worried about the 30 BMI, which is defined as obesity, but higher ones, certainly women who are approaching 50 BMIs, and we have a real difficulty getting them positioned in bed so that they can be tipped over further so we don't have vena caval compression, and it's really an art and a lot of work that nurses have to do to position these women. We can see that same issue with women who have carrying multiples, like triplets or quads, because, again, positioning is really difficult so we don't have vena caval compression. Hypotension can also occur, as we all know, with regional analgesia, and also with be it epidurals or spinal blocks in the operating room, the spinal in the OR for a C-section, but epidurals in labor. This is a patient here with spontaneous labor, but with the epidural, with a great nurse who preloaded mom with lactate ringers and an excellent anesthesia provider, sympathetic blockade can still occur, and vasodilation in the lower extremities of the mother with pooling of blood and decreased blood flow return to the mom's heart, and her blood pressure may fall with decreased perfusion then to the uterus, which we've been talking about, uterine blood flow, and then obviously the resulting fetal heart rate decelerations. So I did ask, let me back up to that question again. So if on the exam, for example, asked about, soon after placement of an injection of a block, the heart rate develops recurrent late decelerations, the most likely physiologic rationale would be, and if they get choices like fetal hypotension or increased vascular resistance or maternal sympathetic blockade, obviously you need to think about maternal sympathetic blockade. Placental changes. There are factors that can happen with the placenta. I've listed some of them on this handout. Let me show you a few examples here on the this first placenta. One of my favorite. I love placentas, and I love to collect pictures of them. And what you can see here is on the right side of the slide that you're looking at is a normal placenta, healthy mom, healthy baby, 39 and 5/7 week. And on the left side of the placenta, of the slide, you're seeing a placenta from a mom-baby dyad that's 36 0/7. Now, that's a few weeks earlier, 2.5 or so. However, that placenta on the left should not be that small. So you have to think further about what's going on. It's a visual of what's happening with that mom-baby dyad. And mom has hypertension with preeclampsia. She worked at home with her husband. They both worked within the house. And husband smoked more than 2.5 packs a day. So you look at this placenta and you look at the smaller size, related most likely to vasoconstriction and concerns with hypertension, a growth-restricted baby. And you can see areas of calcification that are often related to smoking. Mom denied smoking herself, but you think about secondhand smoke, or maybe she really was a smoker and we didn't know. But you can see that on the placenta. The placental picture here, you have a normal placenta on the right, the maternal aspect, and on the left, you can see my hand underneath a clot, pointing to the clot with an abruptio placenta where we have, again, decreased surface area, which can impede, again, oxygenated blood flow to the fetus. And lastly, this is a more complicated placental image to look at. The placenta on the right is looking at the maternal side of a term mother-baby, normal, healthy mom-baby dyad. And on the left is placenta from a 28-week fetus. And how would you describe that placenta? If you're looking right now and you're thinking about it, or you had to chart about it, many of you would say it's or perhaps anemic in appearance. The story here is this is a patient of mine who came into triage, had no prenatal care, was not one of our patients, but we quickly put her on a monitor, and there was heart rate. We had a fetal demise. The resident came in and confirmed with ultrasound. And the history of this woman was she was a G4P1 with one beautiful living child, and had had 2 losses at about 20 weeks gestation. No prenatal care, as I said before. And she had recently moved to the United States. And her history is that she's Rh negative and never had the luxury of receiving a D-immune globulin, or RhoGAM, let's call it, in her previous country, and had obviously sensitization, and we look at with Rh disease and erythroblastosis. So it's an example, and you can imagine how hydropic the fetal demise was as well. But again, thinking about placenta, thinking about diffusion distance in this placenta, how can oxygen and nutrients diffuse across this membrane and exchange? It's just not going to be able to as well. So far we've reviewed the need for well-oxygenated maternal blood. We talked adequate uterine blood flow. And it's about adequate uterine blood flow driving placental exchange at the intervillus level, and a lot of different mechanisms and factors that we deal with every day in labor and birth that can further decrease uteroplacental perfusion and exchange. Next concept and last of the extrinsic factors that I listed on at the beginning of this talk is looking at adequate umbilical blood flow to deliver oxygen to the fetus. And when you look at this umbilical cord, you all can see several things that are concerning about it. You're probably identifying the fact that there's a knot in the cord, yes, and also that the cord is quite thin, doesn't have adequate Wharton's jelly to protect the vessels. And so both are concerns that can lead to cord compression or occlusion, and certainly with cord occlusion we can see stimulation of the baroreceptors, which we'll talk about in a few minutes, and the concern for variable decelerations. We like cords, like in the bottom lower part of this picture, we like those big, thick umbilical cords that have lots of Wharton's jelly and some coiling in them so that the healthy fetus in utero can move and kick and change and pull and on the cord, and healthy cords can withstand all of that and not be as have issues about compression in utero. Umbilical cord that is concerning, since we're talking about umbilical cords, and you have probably seen a cord like this in your experience. These are umbilical cords from, and you're probably guessing already what it is, but monochorionic monoamniotic twins. And see, when we have situations with mono twins, we are concerned about those getting tangled up in an image like this, and so we be anticipating looking, a lot of different things happen with medical management, but certainly if mom is on monitor, and we're talking here today about fetal monitoring, we would be assessing for variable decelerations or patterns that are related to umbilical cord compression. So now let's practice a couple test questions. Again, these, as I said earlier on in my beginning, these are questions that I've written that are similar in type to the kind that you'll see on the exam. Just to give you an example of how simple they are usually written, they're STEM questions. There's usually two types of questions on the exam. STEM questions like this example, or there'll be a question with a fetal heart rate tracing, and they'll give some type of scenario and ask you about the tracing or what you're seeing on it. I know tracing questions really are pretty simple. They don't try to trick you on the strips, and I've really heard any complaints that the tracings are hard to read. So those should be pretty easy, and we talk more about that in the second and third webinar. But specific to physiology and the content we're covering today, they're usually STEM questions. So this is a very excellent example of what they would ask you. So for example, oxygen is transferred from the mother to the fetus via the placenta through active transport, static pressure, or passive diffusion. And as you all know, the answer would be diffusion. And again, this could be passive or simple diffusion or plain old diffusion. Question. And I'm getting some feedback from some of you. Please mute your lines because I can hear some of you talking a little bit. Thank you. Interval space perfusion is dependent on adequate uterine blood flow, oxygenation, or the number of fetal villi. You know, as we've talked about, it would be adequate uterine blood flow. Example question I gave you, something like this: maternal fetal exchange best promoted by which maternal position? Think about this and understand that the questions that they ask you on this exam have to have several articles or chapters, references to current literature for the correct answer. So those of you who are older like me learned long ago that left lateral position was best. We now know that that's not correct, that either the right or left lateral position is better, and this was nicely demonstrated in the Green Journal, or the Journal of Obstetrics and Gynecology article several years back that Simpson and James wrote, and evaluated various resuscitation in resuscitation techniques in the fetal O2 sat monitor measurements, and they found that and what we do know from this that it's either right or left lateral are preferable with higher fetal oxygen saturation, the semi-Fowler, and of course the worst would be supine positioning. So if a woman is unable to ambulate and do have her in bed, then either right or left lateral would be the preferred position, and changing her position frequently. All right. This here is for those of you on the East Coast. I'm over in Seattle. So we've had really a mild winter this year, but this year, the winter of 2014, 2015, I know you guys have been pretty cool and lots of snow. So this is for you all, this picture. Let's move on now and talk about intrinsic factors. We've covered extrinsic factors and understanding that oxygenation can be interrupted at any point along this pathway and fetal heart rate changes. But now let's move on and look at some of the intrinsic factors, some of the ways that the fetus actually works to try to handle oxygenation and increase their oxygenation at times, despite some of the other factors extrinsically that may have been going on. So let's go ahead and talk about these. First, I want to talk about fetal circulation, and this is a kind of complex, and I'm going to spend a few moments here on this slide. Fetal circulation differs significantly from the adult, and in the adult, you and I, respiratory gases exchange in the pulmonary vasculature, and oxygenated blood returns via the pulmonary veins to the left ventricle to be ejected into the adult circulation. In the fetus, blood does not enter the lungs to become oxygenated. Rather, oxygenation occurs in the placenta. A difference is that the ventricles of the fetal heart work in parallel, not in a series, as it does in our hearts. So oxygenated fetal blood enters the left ventricle, which is the heart and brain, and the less oxygenated blood enters into the right ventricle, supplies the rest of the body. And I'm going to trace through this in just a moment, but I'm just trying to give you an overview of the fetal circulation. And this presence of oxygenated blood in the right and left atria in the fetus and great vessels is unique to the fetus and possible by several anatomical shunts, for example, the foramen ovale and the ductus arteriosus. And a third shunt, ductus venosus, allows relatively well-oxygenated blood to enter into the fetal heart directly, bypassing the liver. At birth, we all know that when circulation of fetal blood through the placenta ceases and its lungs expand, these anatomical shunts normally close rapidly a time after birth and cease to function. So look here at, again, circulation, and I'm hoping my point is showing for you. I found a different laser here I've clicked on, so maybe this will work better than the earlier slides. But we've already talked about placental exchange and the intervillous space and oxygenation a few minutes ago, and we talked about oxygenated blood being carried by the umbilical vein to the fetus. Now, this is a nice drawing from Moore again in 2003, and you can see they've illustrated the more highly oxygenated content of blood in the fetus is in the red color, the purple is a little medium oxygenation, and then poor oxygenation is the blue color, pretty obvious as you can see this. Now, highly oxygenated blood, like we said, returns from the umbilical vein, and it enters into the liver, which is quite an important organ in the fetus for the liver uses a lot of oxygenated blood. About 70% of the oxygenated blood perfuses the liver. I want to talk about the 30% that is shunted via the ductus venosus that I mentioned a few minutes ago. Blood is shunted and bypasses the liver, enters into the inferior vena cava, and it's moving pretty quickly under high kinetic energy. Moves into the right atrium, shoots straight across the foramen ovale into the left atrium, if you will, mixes with a small amount of returning pulmonary venous blood, and moves to the left ventricle. And from here it's pumped, so really oxygenated, to supply a little bit of blood to the coronary arteries and the rest to the brain of the fetus. So by means of this ductus venosus and the foramen ovale, the most well-oxygenated blood makes its way to the fetal brain and then to the heart. The stream of blood that perfused the liver, second stream of blood, this blood, again, moves into, this blood here, it dumps also into the inferior vena cava. It's moving a little bit slower. It enters into the right atrium and mixes with some of the deoxygenated blood from the brain, moves in from the right atrium to the right ventricle, and you can see how they've changed the color to a purple, and now shunted via ductus arteriosus into the descending aorta, and then it's able to supply the extremities, for example, the gut and the kidneys and the lower extremities, and then makes its way back to the placenta readily for, again, exchange, intervals, exchange, and oxygenation, reoxygenation. So there are two, again, series here that are going on that they're parallel, not in a series like the adult heart, and hopefully that will explain it to you. I can't see your faces, and I don't know if I made it clear, but I hope I did. I spent a long time on that topic. So if you're asked a question like, what's the fetal blood most highly oxygenated, and they give you several choices like the ductus venosus or the foramen ovale or the ductus arteriosus, obviously, as what we've discussed, is the most high oxygenated blood is here in the ductus venosus. If they ask you of those three choices, which is the least oxygenated, it would be ductus arteriosus. And there could be all sorts of different combinations that they've used in questions about, three different areas, which has the most highly oxygenated blood. But I've explained that well enough. So on. Okay, the next concept I want to cover first, I want to show this strip, and we see your faces, but most commonly when I put this tracing up and I'm in front of a number of perinatal nurses and family medicine and OB docs and midwives who birth babies, they look at this and you look at their cheeks and their faces relax and they get this smile on their face, and it's kind of a Zen-like tracing when we see a normal Category 1 tracing a duplex of baby that's oxygenated, not in metabolic acidemia or hypoxia. We're all pretty happy when we see that. So let's talk about this fetus. And this fetus is quite remarkable. Survive an environment with a PO2 value equal to adult venous blood. How can the fetus do that? How can the fetus survive with such a low PO2? Well, the fetus is quite remarkable in that there are several key points. One, and the front, and these aren't in any special order, is that the fetal hemoglobin concentration is higher than in the adult. Most of you know your hematocrit, and when you think about the hematocrit of a term fetus, it's somewhere around 51 to 56%. I don't think any of us have hematocrit that is that high. Second point, the hemoglobin higher affinity for oxygen than the adult hemoglobin. And talk about this on the next slide when I look at the oxyhemoglobin dissociation curve. And the last point is really a 2-in-1. This has a higher cardiac output on a volume per body weight basis, and so a higher heart rate that we'll know, higher than the adult. And these allow the fetus to have a more rapid circulation, to circulate what oxygenated blood it has. Here's an image of the oxyhemoglobin dissociation curve, and not that they're going to put this on test, but I think this image helps you, again, who are visual learners, make sense of what I just said. This is just simply a relationship. Obviously, on the x-axis, we have the dissolved oxygen, here the PO2 or PaO2. On the y-axis, we have the percent of hemoglobin saturated with oxygen. On affinity, reflects this direct relationship between the dissolved oxygen, the x-axis, and the hemoglobin saturated with oxygen on the y-axis. And if we take a healthy mother, a healthy non-pregnant woman, could be someone in the audience, or a man who's healthy, your curve, we plotted your numbers, would be right down the middle between this green and purple line. So it would be the non-pregnant woman or a man. So what pregnancy does is it shifts the curve to the right. You see the purple line then would be shifted to the right for the mother, causes the mother to have less affinity for oxygen on her hemoglobin. Other examples would be for, if we went over to the ICU and we looked at and plotted numbers for a patient who had severe sepsis, would be another example. So pregnancy or sepsis would be great examples when the curve can shift to the right. The fetus, on the other hand, has a higher affinity for oxygen to hemoglobin and oxygen affinity to its hemoglobin, and its oxygen is more tightly bound, holds tighter, it's more tightly bound to the hemoglobin. And examples would be, let me think, a patient with alkalosis or hypothermia falls into that grouping, or carbon monoxide. So there's various situations that can shift this curve. Now, obviously, those of you with a biochemistry background know it's not this simple. There's a Bohr effect and double Bohr effect, and these lines aren't static, and there's a bunch that it gets involved in this. And as the fetus gives up CO2, the fetal pH increases and becomes more alkaline, and then shifts the curve further to the left with further enhanced oxygen uptake by the fetus. So these lines aren't static. But I think the gist of it is that the mother constantly is giving up to the fetus, and the fetus is constantly taking. And God, I don't know if that many of you understand that concept even after our children are born. So this is why the human fetus can survive on such a low PO2. Now, the second point about this graph, and it really comes out more in the second webinar, is looking at oxygen therapy for in utero resuscitation. And more papers have come out in the last couple of years looking at oxygen therapy and how it's a drug and the free radicals and all of that, and I'm not going to get into that right now. However, what I want you to notice, and just because I have the slide up here and just talk about it, if you look over here on the far right at the 100%, most moms are sitting up there then at about 100% saturation. We talk about putting O2 on a mom, and you think, gosh, well, some people argue, well, she's already 100% saturated. Why are we putting O2 on? But look here, and we talked about the concept of diffusion, and understand that the fetal PaO2 sits around 30. The numbers are usually around 30. And if you look at this curve, it's really, really steep here. This shaped sigmoid curve is really steep here at the levels where it impacts oxygen. It diffuses to the fetus and the PaO2, steep level. So tiny changes in fetal PaO2 have a significant change on oxygen saturation. So hopefully it helps some of you when you think about oxygen as well. Now let's continue on and talk about what happens if there is an abrupt, something sudden, a sudden decrease in PaO2 in a normoxic fetus. So it's completely normal, water variability, perhaps accelerations, no D cells, and then there's an abrupt occurrence. For example, a massive abruption or a uterine rupture or something of that sort. What does the fetus do? Well, it's different than you or I. The fetus redistributes its blood to its vital organs, 2 to 3-fold increase to heart, brain, adrenals, and then it's decreased to the organs that aren't as important for immediate survival, like gut and the spleen and the kidneys and limbs. And as oxygen decreases and decreases and decreases, we know that we'll talk in the next slide about the oxygen depletion cascade, but we'll eventually see the baby develop, if this continues, if this process continues, severe metabolic acidemia. And we can see then a decrease in cardiac output and blood pressure and blood flow, obviously, to the brain and heart, and then resulting in tissue damage or fetal death. Now, here's the classic slide of the oxygen depletion cascade, and this is one that, we all learned back in, obviously, in medical school or in nursing school, and it's pretty simple, but just as a quick refresher, starting off with aerobic metabolism, meaning with oxygen, and then as we take oxygen away, we start off with hypoxemia in the blood, moving the tissue, hypoxia. And when there's lack of oxygen, anaerobic metabolism kicks in, and this is where the glucose now has to break down without the oxygen. Lactic acid can build up. Bicarb tries to neutralize it for a while, and we'll talk more about this in detail with cord gases. And then ultimately, if it's left unchecked, we'll see metabolic acidemia, and then ultimately metabolic acidosis, which is obviously what we're really concerned about and have been talking about. And here's an awful tracing that you all can see. Unfortunately, this nurse and physician were in the room with the patient, and both were unfortunately that there was reassuring signs here with accelerations. I know you're gasping, those of you who are looking at this, and you can see the disastrous outcome here with the APGARs, but more importantly, look at the pH of 6.78 and a base excess of a negative 16. And we'll talk more about cord gases in a few minutes, but this is obviously severe metabolic acidemia. The last area to talk about related to factors that are influencing fetal heart rate, the intrinsic factors, is fetal heart rate regulation. And this is a really complex subject, and I love it. I'm fascinated by it. I like to write about this and been involved in it for a number of years. However, it's overkill for the exam, and so I pulled out 6 or so concepts here that are most important. It tends to be what NCC asks about, and again, I'll give you the reference. A chapter that I wrote, and just a new chapter is being released again this month from the A1's Fetal Heart Monitoring Principles and Practice on the physiologic basis for fetal monitoring. It's on the list that Lydia has. I go into more detail on all of these factors, and you can certainly read that, and I know they take questions from that chapter. So that's a great resource specific to the content we're talking about here today. But this is really quite complex, and, you have obviously sympathetic effect. You've got stimulation of the adrenals and catecholamines, your epinephrine, norepinephrine, hormonal effects. We've got atrial volume stretch receptors. We talk about this with hemorrhage, like a ruptured vasa previa and its impact. Baroreceptors and the aortic arch and the carotid sinuses, as well as chemoreceptors in those locations. We've got proprioceptive receptors and fetal movement that takes place. There's a whole bunch of stuff going on here. So we'll keep this pretty simple. Concepts. First of my six, number one and number two of the six. Let's talk about the autonomic nervous system and the two branches, the parasympathetic and sympathetic branches of the autonomic nervous system. These two branches work hand in hand together to give us the interplay, if you will, which is reflected in fetal heart rate. So when we look at heart rate, it's really a reflection of the interplay between the sympathetic and parasympathetic branches of the autonomic nervous system. Now, I'll talk about sympathetic first, and my rationale for that is maybe you think in terms of gestational age. And I want to talk about sympathetic first because we see it first in those younger babies. So if we talk about 26, 27, 28, 29-week gestation, less than 32 weeks, we usually see a dominance of sympathetic innervation. So the sympathetic nervous system provides a reserve mechanism, if you will, to improve the heart's pumping ability during intermittent stress. And the nerve fibers are distributed widely throughout the fetal myocardium at term. They stimulate the sympathetic branch. It releases catecholamines, which I know as epinephrine and norepinephrine. And the result, it causes an increase in fetal heart rate. Now, I don't want you to go crazy on this and think its heart rate could be any number. This is really the upper level of that normal rate range that we talk about, the 110 to 160 beats per minute. Old school, we used to say that it could go much higher than that, but that's really not accurate. And so when we talk about even these micropreemies and what a rate is at 28 weeks gestation, it's really the upper level of that 160-ish kind of range, and it shouldn't be a lot higher than that. There's an example on a tracing. This is a fetal heart rate tracing at 25 and 2/7 weeks, and you can see the baseline is sitting at about 160 beats per minute. This is a demonstrates sympathetic dominance. It's a normal tracing for this gestational age for this baby. Now, a completely different case, and not this one that you're looking at, but for example, again, if you had a 26-weeker and a mom came in, 2 in the morning and was kind of cramping, and you see her in triage, and the fetal heart rate, for example, is 170 beats per minute, you have to ask yourself, and I'm asking all of you, can this increased rate be explained by sympathetic dominance? And the answer you should be saying is no. Any preterm fetus with a baseline that's greater than 160 should be further evaluated, and things like maternal temperature to rule out infection, because that's not a normal rate for those fetuses. Now, the parasympathetic branch of the autonomic nervous system consists primarily of the vagus nerve, which originates in the medulla oblongata. This parasympathetic gives us a slow, gradual decrease in heart rate that's observed with advancing gestational age, and that's due, again, to this dominance in parasympathetic influence. The difference in baseline heart rate between a fetus that's 30 weeks gestation and term is approximately 8 to 10 beats per minute. So there's not a lot of difference in the big studies looking at the rate of those babies, though it is gradually decreasing as gestational age increases. The primary function of parasympathetic or vagus nerve is the transmission of fetal heart rate variability, resulting from the irregular fluctuations in time between consecutive fetal cardiac cycles. So when we stimulate the parasympathetic with the release of acetylcholine, we see a slight decrease in heart rate. Now, that doesn't mean it's below the normal range. It just brings the heart rate more back into that intrinsic rate, the 110, 120, 130, 140. It's usually not just sitting up there at that 160. And we also see, again, this transmission of variability. Those are the two key points. So there's a slide that I actually put one on, not that we ever run with OTAP monitors like this, but I just put this on as an example to show variability for both fetal heart rate as well as maternal heart rate. Next slide, I just want to talk about it's titled Integrity of Cerebral Function, just to drive home a few more points here about parasympathetic and variability. The presence of fetal heart rate variability, it represents an intact nervous pathway from cerebral cortex down through the midbrain and the medulla and the cardiac exhalatory centers, if you will, down the sympathetic nerves and the vagus, which is the parasympathetic, is really important, and then through the cardiac conduction system. And if the heart's normal and this pathway is intact and well oxygenated, we'll have the CNS responds with moderate variability. However, if there's severe hypoxia and or metabolic acidemia, those can decrease CNS function and thereby decrease fetal heart rate variability. So we all know it's important to remember that the presence of moderate variability reliably indicates a well-oxygenated fetus without metabolic acidemia at the time of observation. And that's a basic principle for everything we do and understand about the fetus and fetal well-being. Moving on, number 3, baroreceptors. Now, those are my favorite. Baroreceptors are these, they're small stretch receptors located in the aortic arch. Where's my little thing again? Oh, here it is. I can't even speak now. My tongue's getting all tied. Aortic arch wall and the sinuses. And baroreceptors are sensitive to an increase in fetal blood pressure. So I think a simple way of thinking about them is that they protect the fetus against extreme increases in fetal blood pressure. So when the fetal blood pressure increases, baroreceptors abruptly decrease the fetal heart rate, blood pressure, and cardiac output to protect the fetus. And you know exactly where I'm going with this. If you have an abrupt decrease in blood pressure that abruptly decreases heart rate, we're thinking about variable shape acceleration. So yes, baroreceptors are really an important factor when we look at cord occlusion. Slide here, pull everything together. I want you to write down 4 concepts. There's concepts here, and I want to write them down because I think that helps think about them in a clearer way, and they're illustrated in this image. First, you need to think about cord occlusion, umbilical cord occlusion, and I'll tie these together in just a moment. But umbilical cord occlusion. Second, increased fetal blood pressure would be stimulation of baroreceptors, or would be a variable deceleration. So we're going to tie these together. Cord occlusion, increased fetal blood pressure, stimulation of baroreceptors, and then full decel. Now, this is a great drawing from Dr. Lee. It's quite brilliant in 1975. It's still brilliant today. You'll see this image, a number of fetal monitoring articles and books related to physiology. And what we can see here is at the top is a variable deceleration, comes uterine contraction, and given us a 2-vessel cord, umbilical vein, umbilical artery. That's perfectly fine. And the last down at the bottom is fetal blood pressure. So right to the middle part of this image, and look at the peak of the contraction, the strongest part of the contraction. We began with cord occlusion. We just talked about the fact that we get an increase in blood pressure, and you can see that down at the bottom of this slide. What has to do with this, with complete occlusion, and both the umbilical vein and umbilical artery are completely occluded, the resulting hemodynamics gives a rise to the fetal blood pressure. And because chemoreceptors need to protect the fetus, they, up at the very top, you can see you get this abrupt decrease, if you will, in the fetal heart rate, which is the classic shape and in the definition of a variable deceleration. So then cord occlusion, increased fetal blood pressure, stimulation of baroreceptors, and then we get the variable decel. Now, the second concept on this slide is one that people get confused with, and I just want to explain it. Think about this partial cord compression at the beginning of a really strong contraction or at the end of it. In this situation, we have partial cord compression. You can see here the umbilical vein gets occluded, the artery stays open, and in this situation, actually the baby's blood pressure, the fetal blood pressure drops. When fetuses drop their blood pressure, they're no different than you and I. Their heart rate increases, if you will. There's this little temporary kind of increase to the heart rate. And I want to point this out because some people get all excited about these and call them by all different names. And I want to make it clear that this is just these increases here and then maybe at the end after the variable. They're just part of the variable deceleration. In olden days, people called all sorts of different names. I don't even want to say the names right now to confuse people, but don't use that language. These are just parts of the variable. They may or may not appear depending on how quickly the contraction causes partial versus complete cord occlusion. So if you look at this slide, you can see at the beginning here, you have a little bit of a partial and then complete occlusion. Here it just happens so quickly to complete occlusion, you don't get those increases on either end. Here you see it post towards the end, et cetera. So I'll see those. They, just like the term variable, they're variable with each different patient or mom-baby dyad. Okay. So if you're asked, for example, about an abrupt rise in fetal blood pressure can stimulate what kind of decels, based on what we've just talked about, if you have an abrupt rise in fetal blood pressure, it can stimulate variable deceleration. So if they asked you about early, later variables, you'd know the answer would be variables. Let's go on to number 4 and talk about chemoreceptors. Chemoreceptors, confusing. Chemoreceptors, these two slides of mine have to do with of adult chemoreceptors. Chemoreceptors. Oops. Oh, I'm sorry. I had a slide. Sorry about that. Adult chemoreceptors. That's why I'm confused. Chemoreceptors, adult, both peripheral and central. Peripheral ones are located in the carotid bodies and the aortic bodies. That's the same as the baby, but their actions are slightly different, though the net result will be the same. But you can see here in you and I got chemoreceptors, abrupt changes in PCO2, PO2, and pH. And here we can see central chemoreceptors responding to mild changes. So think about chemoreceptors' primary function is to regulate respiratory activity and control circulation by responding to changes in arterial PO2, PCO2, and obviously acid-base balance. And we understand these a little better in the adult than in the fetus. So when we talk about the fetus, the interaction of both central and peripheral chemoreceptors seems to be a gradual slowing of the fetal heart rate. So often folk will talk about chemoreceptors related to late decelerations because with you have often a decrease in uterine sentinel perfusion and oxygenation, and then the chemoreceptors sensor this, and you get this gradual slowing of the fetal heart rate. And so chemoreceptors are often, like I said, described in the mechanism of late decelerations. But so, if you go a little higher level thinking, chemoreceptors can also be seen in the mechanism of variable decelerations, specifically when we have fetal cord occlusion coupled with hypoxemia. Now, test, I don't think NCC gets into it that complicated. What they'll show you primarily will be variable decels, or ask you about, like we just did, variables and baroreceptors and cord occlusion. And when they talk about chemoreceptors, they'll be looking more at late decelerations. But in real life, they're often combined. There's different degrees of influence by each one of them, and it gets really fun and really exciting. But we won't get into that here and now because we'll keep, again, very simple for review for the test. Here's a tracing that would illustrate chemoreceptors stimulation. This would be recurrent late decelerations. We also have minimal to, looks like absent variability at baseline, and then we have also tachycardia of about, what is that? I can't even read it here, 170 or so beats per minute. So this would be an example of chemoreceptor stimulation. The fifth concept is looking at cardiac output. And before I talk about the fetus, I want to make a few comments about the adult for a comparison. In the adult, we know that a heart rate is related to cardiac output and stroke volume in the following equation. Cardiac output equals heart rate times stroke volume. And we all learned about this, in the Starling mechanism in our training. So for fun here, and just for a moment, if you'll pretend, just to make a point, pretend that we're going to put in here, the woman sitting on your right, somebody sitting next to you, on your right, she does Iron Woman. She trains for Iron Woman, and not just your local triathlons, but she goes over to the Kona coast of Hawaii, and she gets up there and swims her mile or two in the ocean, and then gets on her bicycle and rides 110 miles up the Kona coast and back in, and then runs a 26-mile marathon. And if you think about her sitting right there, what's her resting heart rate? Maybe thinking like 48, something like that. I usually hear people holler out. And they pretend like the woman sitting on your left, her exercise, a long day's work is she comes home and she plops herself on that big sofa and she turns on Dancing with the Stars. And what's her resting heart rate? 88 or so? So when we think about these two women, they're women with approximately the same cardiac output, but their heart rates are quite different, 48 compared to 88 or so. So what we know is in the adult, stroke volume can fluctuate to maintain cardiac output. Now, this is a problem for the fetus. Compared to the adult, the fetal stroke volume does not fluctuate significantly. So cardiac output is essentially rate dependent. So fetus develops a bradycardia, the heart rate's dropped, you've had like a prolonged decel that's now running into a bradycardia, heart rate's getting lower and lower, that can no longer increase cardiac output, and different numbers get thrown around, but certainly approaching 60 beats per minute, all bets are off. So if the fetus's ability to regulate cardiac output is based upon altering what? Everybody here understands it would be altering heart rate. All right, and then again, thinking about cardiac output getting really low, we have to think about, obviously, the development of lactic acid and metabolic acidemia and acidosis. And this example in a tracing with a massive abortion, again, that heart rate getting down there, 60, 80, sort of bouncing around like fetal heart rates do, 60, 90, back down to 60 right before birth. And we can see the impact of cardiac output and relationship with cardiac and output, and heart rate in this baby had severe metabolic acidemia. The sixth and last concept that I talk about specific in heart rate regulation, the idea that the heart rate is also influenced by fetal sleep and wake cycles, which begin to emerge during the third trimester. Now, sleep-wake cycles in the fetus and the infant, the newborn infant, are qualitatively and quantitatively different than the adult. They're commonly referred to as states, and are most often defined by a specific combination of three variables that I've tried to illustrate on this slide, which are rate variations, the absence or presence of generalized body movements, absence or presence of rapid eye movement or REM. And you get those here on the slide. Early pregnancy, fetal movement is largely continuous, just little general continuous movements. However, with increasing maturation and gestational age, periods of quiescence emerge, and by 38 weeks, 36 to 38 weeks, the normal fetus cycles primarily between periods of sleep and wakefulness. This wake cycle is credited with being the prenatal version of alterations of quiet sleep and active sleep. So some of you are going, where is she going on this slide? And yeah, you're probably right to wonder that. But the exam has occasionally asked about this, so I thought it would be prudent for me to bring this up. And specifically, what I want you to take home from what I've just said is if you look here at the, I don't know about the state, but if you look here at this constellation of those factors I talked about, frequent body movements, moderate variability, accelerations with movement, what you and I think of as an awake baby. If you ask about it, it's really active REM sleep. And this, of course, would be the baby that we're talking about is going through a sleep cycle. So just to be aware of that, if you get something that looks like this on a tracing or they ask about this or describe it, it's not awake, it's really active REM sleep. So let's do a few more practice questions for this section that we've talked about. Variable decelerations are mediated primarily by, you're all thinking to yourself, baroreceptors. If I asked you late decelerations are mediated primarily by, you would say chemoreceptors. And if I asked you about early decelerations, your response would be a vagal response. Question. The sympathetic branch of the autonomic nervous system induces the fetal heart rate to, and thirdly, you're all saying increase, as if I asked you about the parasympathetic branch, and your answer would be that it would be to decrease. Average difference in baseline fetal heart rate between 30 and 40 weeks gestation is, we taught this, 8 to 10 beats per minute, so 10 be the appropriate response, and we know that this baseline decreases during gestation. I think I just have one or two more. During an acute episode of fetal hypoxemia, and this fetal blood flow is redistributed primarily to the. Talked extensively about this, and this is all covered on the slides that we've been through. And then lastly, chemoreceptors respond primarily to hypoxemia. All right, job. Oh, doesn't that feel good? Now I have to tell you again, those of you from the East Coast, that is sand, not snow. I know you've seen too much snow, but especially Boston, but that is sand. So I'm thinking of you guys. Okay, let's move on now, and we're going to talk about acid-base medication. But before I do that, where have we been in this talk so far? We've talked about a number of key influences on fetal oxygenation that have the physiologic basis for fetal monitoring. We've talked about maternal oxygenation and uterine blood flow and the importance of uterine blood flow to just drive that exchange within the umbilical space of the placenta. And we've had umbilical flow. We traced fetal circulation, and within that we looked at the shunts, and we talked about fetal oxygen affinity and how it's increased. And we also looked at cardiac output in the fetus and how it's pretty directly related to fetal heart rate. And lastly, we talked about 6 or so key concepts related to fetal heart rate regulation. I'd now like to jump gears a little bit and talk about umbilical artery cord gases. And I'm going to try something here where I want to, instead of just being crazy and just walking through gases, I want to try to relate the heart rate patterns, basic heart rate patterns, and whether or not directly to the umbilical artery cord gases, and then sort of pull it all together to have it make clinical sense. So this is relevant to everything you do. So this slide here has a lot of writing on it, but it covers some key points as we get going here. I think everybody knows that we use cord gases as an objective determination of fetal metabolic condition at the moment of birth. They don't do anything else. We use them to manage the the neonate. For that, they're just used as a form of documentation about the metabolic state at the moment of birth. Now, there are various attorneys and different practice groups as I go around the country that are now being requiring certain practice groups, physicians, individual physicians or groups to get cord gases sometimes for all of their births for a limited period of time, just maybe could have had a bad outcome or whatnot. You can only guess. But that's pretty rare, and most commonly gases are drawn for certain conditions, and the physician or midwife makes this order. So examples of conditions to cord gases would be abnormal fetal heart rate tracing. That's one of the most common, or a C-section for fetal compromise. The other most common ones would be a low 5-minute APGAR score, or infant fever. This is quite interesting because as many of you have had patients with GBS positive, and they're on antibiotics, some of these babies will have great gases, great initial cord gases, but then they may have a difficult course in the NICU afterwards. So cord gases can be really valuable. And then ACOG multi-fetal gestations, thinking about some of those micropreemies, if you have, multiples, that APGAR score may not be very effective in assessing the baby. And as many of you know, Virginia APGAR developed the APGAR score really for term chubby babies. That as a quick way to assess them. And so it really has limited application to those smaller babies. And then, of course, any other reason that the provider may desire to order cord gases. So I think it makes sense for nursing to, again, ask the doctor or the midwife within 5 minutes or so after birth, because we need to make a decision, and then we need to get these gases to the lab promptly. Historically, the older ACOG bulletin said, 60 minutes. The gases would be fine in a heparinized syringe for 60 minutes. However, there's some newer, smaller studies that are coming out in the last couple of years, and then certainly the ACOG AP, neonatal encephalopathy and neurological outcome, the second edition in 2014. Both that document and a couple of the newer papers are saying that you really need to analyze the sample expeditiously, and that while pH seems to be unchanged over the 60 minutes that it's been drawn, or in the clamp vessel or in the heparin, base excess and lactate in some studies has changed significantly, and so you don't want base excess and lactate to be moving in the wrong direction, because that would be more indicative of metabolic acidemia. So I think it behooves people to think about getting these to the lab, and also periodically have somebody check with the lab to make sure they are running these right away. You don't want these sitting. You need to understand the significance of doing these and getting them run. So here's that slide again we've been talking about several times today about oxygen depletion cascade. And again, this is really important when we think about cord gases. So again, I'll be pulling this out and you'll see it in a few moments, but aerobic metabolism, again, with oxygen and glucose moving into the fetus. And then if we start taking away oxygen, make it clear to everybody here that's listening that hypoxemia is in the blood tissue. Hypoxia would be in the tissue. And moving on into anaerobic, which we'll see as I move on into talking about metabolic acidemia, and I'll try to make this pretty clean to everybody. And then one more quick comment before I get going here about metabolic acidemia. People get really frightened when they see that on the cord gases, but to keep it in perspective, remember that even in the presence of significant acidemia, most newborns will be neurologically normal. And these two bullet points here come out of the 2014 ACOG AAP neonatal encephalopathy and neurological outcomes. So I'm trying to make you all feel a little bit better. Okay, so now let's try to relate these tracings with gases. So here's the first one, and this is our Zen tracing. And it's completely normal, category 1, we couldn't have it any better than this. Moderate variability, presence of accelerations, no decels, normal baseline rate. We're all super happy with this. So what's going on? Now these are some drawings that I made some years ago, and over in the blue is my placenta, And you can see the umbilical vein carrying in the oxygen and glucose. They're diffusing over to my fetus, which is this egg, if you will, this oblong circle here, this oval. The glucose and oxygen break down to CO and water. The fetus utilizes the water, and then the CO2 starts to build up. And as we talked about earlier about diffusion, CO2 is higher in the baby, and then it's able to diffuse back out via the umbilical arteries to the placenta for exchange. A little bit more goes on here. You can see with my carbonic acid, but that doesn't really matter to anything we're talking about today, so don't worry about it. So the key point is with normal metabolism or aerobic metabolism, oxygen, glucose move in, a little bit of breakdown here, CO2 moves back out. And when we look, this is with the normal tracing, and we think about what are the normal gases, we can look at these numbers. Now, your handout that you all have will not have this slide. You will have in a few more slides in your handout one big table that has all these numbers on it. And I've done is I've just pulled little segments from that table just to try to focus you on what I'm talking about. So you have all these numbers in your handout. So as you can see here, I made a table with pH, CO2, bicarb, and base excess. I'm hoping that most of your hospitals report in base excess. Some of them may report base deficit, and I'll address that in a few minutes. So let's look here first. We're talking about a normal tracing, normal baby. The only thing you really want to look at here initially is what is the pH. And there are means of all of these values. You can pick up, my favorite book, Crease and Resnick's Maternal Fetal Medicine, or you can pick up, for example, depends on what part of the country you're in, Williams Obstetric, or you can pick up Steve Gabby's Normal and Problem Pregnancies if you're more up in the Ohio area. So you can pick up whatever these books you want, and pretty much all of them, they're resource books. You can go back and read about cord gases, and they'll give these ranges. They're all based on studies that were done several decades ago, and in the studies they use the term predominantly acidosis. We know that acidemia is really a more accurate term now. So you'll hear nurses and physicians interchange those terms, acidosis, acidemia. I don't think it really matters. I'm trying to be more technically correct today and use acidemia. But you guys in your own practice can do whatever, and on the test it may be written both ways, or one way or the other. Have no idea. So the key here is, in a normal tracing, a baby with normal acid-base status, we want to see a pH, a well-oxygenated baby, a pH of greater than 710 to know that it's not acidemic. So that's a magic number that everybody memorizes, 7.10, not the range. All right, so let's move on. Different sort of tracing. We've just covered the normal baby, normal tracing with normal acid-base pH, and also normal APGAR scores. So let's move on to something different. Here's a tracing with variable shape decelerations, variable, the baroreceptors. We think about cord occlusion occurring. And in this particular case, when we look at the gases now and what's happening, and we're going to have now here intermittent disruption or occlusion of the umbilical flow. So there'll be some issues with these variable decelerations and oxygen and CO2 getting in and out. The result of what usually happens here is that you end up with a buildup. I wrote over here on the a buildup of CO2. It has a harder time getting back out. And so the CO2 begins to rise in these situations in the fetus. So if we go and look at our core gases, we first look at our pH. Our pH in these situations will be decreased. Now we have some type of acidemia. It could be metabolic or it could be respiratory. We have some type of acidemia because the pH is less than 7.10. So what we teach people to do is first look at CO2 because most commonly it's a respiratory issue. And if CO2 is 60 is the magic number. If it's greater than 60, back a slide, with all this trapped CO2, the number goes up. It's trapped. It increases. We have increased CO2. We have now respiratory acidemia. So pH, high CO2, respiratory. Now what APGAR score may we see with this baby? Variable D cells. We may see an APGAR of 7.9. The baby bounces back quickly, 5-minute APGAR score because there's been interruption due to the cord, but little oxygen low by whatever, baby on their own just bounce back and do fine. All right, continue. Another concept. Here's the next one. Here we're in this tracing number 3 where we have late decelerations. And I guess I should have picked one with less variability. Sorry about that, you guys. We have recurrent late decelerations, and let's say the variability is decreasing as well. And what are we thinking about now? Well, with decreased variability and we have late decels, we're thinking about the baby has less available oxygenation. And with this, over time, we start kicking into anaerobic metabolism. We've lost the oxygen to mix with the glucose, and now the glucose breaks down with oxygen and becomes lactic acid. So all these H ions floating around, and initially the fetus moves in bicarb, the base. Base comes in, the bicarb, and tries to neutralize the acid, and it does a pretty good job for a while. However, if this continues and the tracing gets worse and we lose variability and on, we can develop metabolic acidemia. And this is where the base is depleted. It's overwhelming acid, lactic acid, which can lead to cellular death. So what would that baby look like? Well, the pH, again, would be low, less than 7.10, the magic number. Second, we'll look at PCO2 because we don't know which it really is with a low pH. We're just going to try to figure out. We go to CO2, is less than 60, so it's not trapped. It's not a CO2 issue. It has nothing to do with the cord compression. Then we move on and look at the bicarb. Now, bicarb has been used up. It's starting to fall because it's been trying to neutralize the acid. Remember, go back on the slide. Remember, our base had moved in, but now it's going down or it's been depleted. Numbers are dropping here. So we'll lower bicarb. Last way to look at it, you can either look at bicarb or base excess. I tend to personally look at base excess, which is computed by lab. Base excess decreases. Now, I know you all are good in math, but I just want to make a very basic key point here, which is when you say less than or equal to a negative 12, less than a negative 12 is negative 14, negative 16. You're moving away from 0. So less than a negative 12, negative 14, negative 16, negative 18 would be getting into more severe metabolic acidemia. So you can look at it that way. Another point I said I would make is for those of you who report, you don't get base excess from the lab, but your lab reports base deficit. Base deficit, you sort of switch the signs. So norm base deficit up here, instead of being a negative 3 to with a plus minus of a negative of 3 or 4, instead of being this, you would be positive. It would be a positive 2.7, a positive, so it could be like anywhere from 1 to 5 or something like that. You would get this range, and then would be reflective of acidemia would be the number 12, a positive 12 or 14 or 16 or 18 in the positive range. So that would be with base deficit. What I do, and I think many of you, I try to teach you guys to do, is when you look at base excess, I just take the absolute value of the number. If you just get rid of the plus or minus sign and just look at the number here, 12 or bigger, 12, 14, 16, 18, 20, those are all related to acidemia. So I quickly look at pH. If it's less than 710, I look always at CO2, and I know the number of 60. Memorize that number, and is it greater or less than? Do you have trapped CO2 or not? And then I jump over and look at base X. So that's my little hint to all of you to make gases really easy to look at. And another key point here that I want to make is that when initially you think about a normal tracing, and you have, it can go and just be fine. And for it to develop significant acidemia, for that baby to develop significant acidemia, it takes time. 60 minutes are what most people are talking about. This originally came from work that published that had 60 to 90 minutes, but you'll see over and over the number 60 minutes. And this is not with a catastrophic event. We're talking just a normal tracing that develops an abnormal pattern. It takes time to do that and develop significant acidemia. So this is good news for us, I think, at the bedside. And it gives us time to identify the problem and to intervene, start in utero resuscitation, mobilize everybody, make decisions about delivery or birth, and that's important, and I think that's a key number to keep in mind. And the other, lastly, I just want to show one more strip, and this is one in which you can have a mixed metabolic and respiratory acidemia. Here you may have something like in this particular baby, you had initially variable decelerations, and now these variables are getting deeper and they're lasting longer. The baseline's rising, and in a few minutes the variability diminishes, and it's really an example of a baby transitioning between respiratory and now developing some metabolic acidemia, and this would be a mixed acidemia for you to be aware of. So here's the table that you have in your handout, showing you all of the values, and you have that for your own reference. So let's go on now and do a few practice questions so that you'll feel comfortable with these if they're on the test. I know have been this versions of the test. You may have 2 questions on acid-base. I've heard other tests people have had like 4 and 5 questions. It really depends on the version you get. So here we are with cord gases. So the first thing you do obviously is you look at the pH. pH is 7.22. Right, everybody should be able to say that's normal acid-base status. You don't need to go any further. Once you look at pH, if it's normal, you're done. Greater than 7.10. But practice, you can see here that the PCO2 is 50, so that's less than the magic 60, so its CO2 is not trapped. And base excess here is essentially -3 or 3. So, and by carb 24, the magic number was 22. So you can pick up the fact that this is completely normal. Here's one. Peak of 7.04. So you are all identifying that as low. Look at your CO2, and 2 is 80. That we have trapped CO2. It's greater than 60, so there's a respiratory component. We move down and look at normal, base S a -4, so we have respiratory acidemia. And then pH 6.98, low, so 49, below 60, so it's not a respiratory issue. About 16, less magic 22, so it's been depleted. And excess is a -16, so metabolic acidemia. Here's more. pH 7.02, so 78. That's greater than 60, so we have a respiratory component. 17, it's been used up. It's less than 22, so we have some metabolic, and base S a -14 metabolic. So this one is mixed acidemia, respiratory metabolic. This may also be written in this type of format. So respiratory acidemia is indicated by an umbilical artery cord blood gas, pH of 7.04, and a CO2 of. I'm not sure that you all, I'm hopefully I made it clear to everybody, on these cord gases, even though at the time you draw the gas at birth, you draw both the artery and vein, the nurse draws it, or the respiratory therapist, in some hospitals the physicians draw it. It depends on where you practice, but they draw from both the artery in one syringe, the vein in the other syringe, in the second syringe. Both sent to the lab, but when we look and interpret these gases, we always look at the umbilical arterial sample, because that's the blood leaving the baby. That would be most reflective of the fetal status. So you have both samples. Some people go, why do you draw from both? It's just because, again, it's able then to demonstrate which vessel you drew it from. Trust me, plaintiff attorneys are pretty good at this, and if you only have one sample, they'll argue that, they just drew it from the vein, which means the values are better. They're inflated. They're better than what they really should be, and they didn't draw it from the artery, which would have reflected a poor status in the fetus. So you want to be sure you draw from both, but you're interpreting artery. And sometimes when the values come back, you can look at them and you go, wait a minute. The vein values are worse than the artery. It's because they've switched them, because they were labeled or drawn. People missed which vessel they were drawing from. And there is an occasion, and it's happened to all of us sometime in our career, where the values come back and they're exactly the same for both artery and vein. And it just lets us know that, oops, we drew from the same vessel and we really didn't get two separate samples. And it's happened to me long ago, too. So it does happen. And there's one more question. Fetabolic acidemia is indicated by an umbilical artery cord blood gas of 6.94 and base deficit of -15. So you guys have this. We spent quite a bit of time on it, and I think that part you've gotten down extremely well. So I'm going to take a few moments. Back here, I'll just leave the slide for a moment. I did mention the readings, the recommended readings I put out for 2015. I think Lydia will probably have them posted somewhere. I can't hear her right now, but I believe she will have this posted somewhere for you. And again, it's a really simple one-pager that starts off with the breakdown of the sections that NCC tests on, and then I give some headings like EFM equipment, which I know people miss questions on, or physiology, or pattern interpretation and interventions, and then adjunct fetal assessment. I've given you a couple of readings, or sometimes it's just one single reading, like an ACOG bulletin specific to that topic to focus you. And then I also listed of general interest several books that are just general reading, if you may want to use as a reference. But I should be very, very specific and very focused for the exam and what seems to be occurring on the test, so everybody can do extremely well. And lastly, I want to just take a moment to talk about the test. Those of you who may not be listening to the other webinars, there are 125 questions on this subspecialty exam. 10 of those questions are counted for scoring. Obviously, what happened to the 15? Well, you can see that I would hear that 15 are embedded pre-test questions and they're not counted. So what that means, because it's kind of goofy, is that you'll go along in the test and you may come to question number 14, and it may make no sense to you, and it may be one of these questions that they're just trying to see how it performs, and they won't grade you on it, but you don't know that. You don't know which question it is. And what they're trying to do is see if the high performers who are every question right on the exam get that question right, or is it a question that they miss? Something's about that question that just doesn't make sense to them. And they're also looking at those who are doing on the exam that aren't doing as well, and seeing whether they get it right or not. They keep statistics on every one of these questions. They do all this psychometric testing on the questions themselves, and it's very, very sophisticated how they do this. So they work really hard to make sure that the questions are good questions. So I'm trying to say to you, as you go through the test, and you will occasionally come to a question that's just kind of goofy, and you do your best. I shouldn't say goofy, but you understand what I'm saying. You'll get to it. It makes no sense. But remember that you're not penalized for guessing. So just put something down and move on, and don't panic about it. Each question will have a stem and then 3 alternate answers, like I demonstrated for you today. And note that the answers are alphabetized. So you may be writing on your answer sheet B, 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 B. That's okay. Don't go back and change it. It's all organized how it comes out of their test bank. And in fact, in each of their categories, they randomly pull out questions. So like when you get into doing questions about court interpretation, and maybe you have several questions in a row that you're marking something related to variable decelerations or cord compression and variables, and you start to think, God, I better go back and change an answer. There's too many answers I'm doing on variable decels. Don't do your answers. Leave them alone. you're probably right. I'm most likely you are right, because they come out randomly out of their test bank, and they may be questions on variable D cells this time. So don't panic about that. Just go through it and work your way through the test. They test both basic knowledge and application. I've done that a little bit with you. And while the physiology section doesn't really have too many strips that you would look at, they'll mostly be related to the other two webinars. The tracings, just know that they're set at 3 centimeters a minute, just like what we look at. And I've not heard anybody complain about the difficulty in reading them or their quality. They seem to be pretty easy to interpret. They don't try to make you decide between absent and minimal when definitions somewhat overlap, like we all know, and it's very, very difficult sometimes to distinguish. They aren't going to do that to you. And the exam is 2 hours long. You get 2 hours allotted to complete the exam. Most people are done in about an hour and a half, and you'll see folks, the fastest I've seen is about 45 minutes, 50 minutes. Now, I don't know how well they did on the exam, but you'll see people come at that time. And in 100 people, maybe 15 that stay right up until the 2 hours. You usually hear that they're usually in the room. I'm not in the room. I'm sometimes outside of the room, but they'll be there up until maybe about 2 hours, going over their answers and whatnot. So you have to keep moving. You can't lollygag through it. But the idea that 2 hours, I think that's pretty reasonable for everybody to get through it, and it doesn't take, most of you won't take that long. So thank you. And I hope this was worthwhile and helps you in your preparation for the exam and just in your everyday clinical practice, giving you understanding, I think, the physiology behind what we interpret. And then I feel so strongly that once you know the patterns and you memorize those, you really have to understand the physiologic basis of monitoring and the physiology we've talked about to help drive your interventions. And when you can connect all of those together, oh my goodness, it's so much easier, and I think we're better nurses and physicians and midwives when we do that. So that I will, escape from this. That I can see questions. I'm going to unmute myself.
Nancy, you muted yourself.
Oh, can you hear me now?
Now.
Okay, perfect. Now, I'm unable to see questions, but I would love to entertain any questions. I can't see the written ones anywhere.
Now, if you go up to the top, Nancy,
so maybe
you can just barely see viewing your ask. You go up, a little screen will come down and it'll say chat. Although at this time, unless they were sent to you privately,
no.
I see no questions.
I see that. And would anybody, if anybody has questions, I'm right here. You say your name and then ask me your question, and I'd be more than happy to answer it. Any questions?
Thank you. Very clear.
Thank you. Any helpful? And again, Lydia will get the, make sure it's posted somewhere, the readings.
Yes. Thank you, Nancy. Once again, it's an excellent presentation. Nancy has been doing these presentations for us since 2010 or 11, and always gets very good reviews. So if you get an opportunity to listen to the other two webinars or see her live, I'm sure that you'll benefit from that. This concludes today's presentation. Please remember, in order to receive any CME or credits for participating in today's webinar, you do need to go to the onto the URL that is posted in the chat, or that was also sent out with instructions with the invitation. We thank you for your participation today, and the playback, we hope, will be posted by the end of the week, and I will make sure that a notice is sent out to all of the EFM coordinators regarding that. For the recommended readings that Nancy has mentioned, all of those have been provided to all of the coordinators, the EFM coordinators at each site. However, if you're looking for them, they should be posted on the Perinatal Patient Safety Initiative website. However, I will confirm that and make sure that they too are there before the end of the week. I make a commitment to the end of the week because I do know that the individual that's responsible for that site is out for a couple of days. So I know that we should be able to get it by the end of the week. So thank you, Nancy, and thank you all for your participation.
Yeah.
Good day.
Thank you.